Hi, and welcome to Coffee, Kids, and Orthopedics on Demand. I'm David Podeszwa. I'm the clinical director of our limb lengthening and reconstruction service here at Scottish Rite Hospital. Today, we're going to be talking about limb length differences A to Z, assessing and managing limb length differences in the growing child. I have no relevant disclosures for this talk, we're going to take just a minute and go through the objectives of this talk. The first objective is we're going to discuss the common etiologies of limb length differences in children and adolescents. After this talk, you should be able to describe the ideal technique for clinically assessing a limb length difference. You should be able to compare and contrast the options for treating a child or adolescent with a limb length difference, and should be able to identify the indications for non-operative and operative treatment of a limb length difference. Today, in talking about assessing and managing limb length difference, we're going to review the etiology of common limb length differences, history and physical exam, the radiographic assessment, predicting a limb length difference, different treatment options, and the timing of intervention for these differences. First, we want to start a little bit general, and really, does a limb length difference make a difference in the long-term function of a child and an adult? And we know that the asymptomatic leg length differences of less than 2 centimeters is relatively common. And I tell families all the time that there are millions of people in the world walking around with a 2 centimeter or 2.5 centimeter, which is an inch, right? So an inch or less difference, and they don't know it, and it doesn't have any ill effect on them over the course of time. And this has been shown to be very common throughout different populations. Whether this has a long-term impact really is still unclear and somewhat controversial when you're asking, does a limb length difference make a difference on low back pain or degenerative joint disease? We know that from our own studies, and we're going to review this a little bit later into the talk, that with instrumented gait analysis studies, they generally show that there's no significant functional disturbance when you have a leg length difference that's less than 3% of the contralateral long side. So if it's less than 2.5 centimeters or less than an inch, it doesn't really have any gait disturbance and generally won't have any functional disturbance. So really our goal at any time is that at the time of skeletal maturity, if we have a limb length difference that's less than an inch or ideally less than 2 centimeters, then we feel very comfortable telling the patient and the family that this isn't anything to worry about and that this will not have any ill effect on the ankles, knees, hips, back along the way. And that usually is very helpful for the family to know that that's the goal and to have a little bit of difference. So when you see a patient in clinic, particularly the skeletally mature patient that might have just a subtle limb length difference, if they don't have any other underlying problems and that's all they have, then it's easy to reassure them that that's not a problem. General principles of evaluating the patient is important, particularly when the patient is younger. So we want to give a really broad overview of the patient, and you can do that relatively quickly, and that's going to give you some idea of pointing to an etiology of a limb length difference. So obviously when you're evaluating a small child, and these are things you're going to do naturally anyways, but when you're evaluating the small child, we're going to check height, weight, head circumference. We're going to screen for abnormal facies. We're going to look at their back to see if there's any hairy patches, any dimpling that we might think of spinal dysraphism, torticollis, digital anomalies, foot deformities, and then also with limb length differences, is there a difference at that time? And if there's a difference and then we see some of these other things, then that's going to point us to more of a congenital etiology. We want to do a good hip exam. Limb length differences can be associated with hip problems. A hip problem in itself can look like a limb length difference, and that's important to pick up, and we'll talk about that in just a minute as well. Evaluate the small children while they're walking, playing, and just behaving in the room. And something that you typically already do, but we look at it very much from a musculoskeletal, from a function standpoint. Are they limping? Are they able to sit, stand, walk, crawl? Will they run away from you? They'll typically run away from me. They won't run to me. They'll definitely run away from me. And we want to be able to see their legs and their upper extremities. If they come in sweatpants, everyone is placed into shorts. Take their shoes and socks off. Look at their feet. It's a very good. The feet can be a really good indication of something else going on and have some very subtle findings. So the box on the right-hand side of your screen is just a quick rule-out examination. It's a very easy, quick orthopedic examination, and a lot of times can rule in or rule out whether what you're looking at orthopedically is related to something neurologic or something related to a congenital issue or a developmental issue, or is the patient really just normal and there really isn't anything underlying. But all of this can be done very quickly, just within a minute of having them walk, hop up and down, hop on one foot. And it's as simple as hopping on one foot. Whether they can do that symmetrically is important, and whether they can do it at all is important. And it sounds easy, but it actually requires a fair amount of strength and coordination. Heel walk, toe walk, walking on the lateral border of their foot, squatting down, standing up, sitting on the floor and standing up without the use of their hands, and having them do that quickly. All these things, it's very easy to do, very quick, and within a minute or two, you've got a pretty good idea of whether their coordination and their function is normal. And that helps, again, guide where this etiology of limb length difference may be coming from. And again, when we talk about the etiologies, there's broad categories that we look at. Congenital limb deficiencies, neuromuscular disorders, post-traumatic, growth disturbances, and hemiatrophy syndromes. And we're going to talk just a little bit about each one of those right now. When we look at congenital deficiencies, we're going to talk about a couple of them right now. Posteromedial bowing. So this is a bowing of the leg, and particularly of the tibia. So the posteromedial bow, meaning the tibia will be bowed posteriorly into the medial side. This is most commonly associated with a calcaneovalgus foot at birth, meaning that the foot, the dorsum of the foot, is plastered up against the anterior tibia when they're born. And it's a very alarming condition. Can be very alarming for the parents when they have this foot deformity when the child is born. It can also be associated sometimes with some knee issues like hyperextension of the knee as well. But typically the foot deformity is obviously what's seen at birth. Now, the good thing about what we call this calcaneovalgus foot deformity is that it responds very well to simple stretching. Very occasionally it might need to be casted, but it responds well to stretching. The patient is left with a bow in their leg, but most commonly this type of bow will straighten up with growth. Now, it may not completely straighten up with growth, and it's not going to do it quickly. It's not going to be on the scale of months and years. It's not going to be a few weeks, and even at the first birthday, they're still going to have a bow in their leg. Most of the time, and it's I would say the vast majority of time, this doesn't have any effect on their function. They're going to be running, they're going to learn to crawl, they're going to learn to walk, they're going to start running and jumping and playing, even with a little deformity in their tibia, and it's not going to necessarily have any ill effect on their foot or ankle. But it will take time, and most of that bow will go away. However, the long-term effect of this condition is that they're usually left with a leg length difference at the time that they're done growing. And the most common, as it says here, is 2 to 6 centimeters, but generally 3 to 5 is by far the most common amount of discrepancy that they will have at the time that they're done growing. And this is important just to follow along. That amount of discrepancy doesn't really require any treatment until they're closer to being done growing, when that can usually be dealt with what we call an epiphysiodesis, or slowing the growth of the long leg so that the short leg can grow and catch up. Very rarely, if it's more 5 or 6 centimeters, we'll do a lengthening, and we'll talk about that later in this talk as well. The key here, though, is the foot deformity will get better with some stretching and manipulation. They'll be left with a leg length difference when they're done growing. When we talk about anterolateral bowing, almost the opposite of the posteromedial. Again, we have a bow in the tibia, a bow in the leg bone, where it's going to come out both to the front and to the outside. This is a much more concerning deformity and leg length difference because this bow is associated with changes in the bone, much as you see in the image on the right-hand side of the screen. With bowing, you can see cystic changes within the bone. And in this image, you can see that there is an actual pseudarthrosis. So there's a false joint. This child was born with what is believed to be a fracture in the tibia, which isn't truly a fracture. It's that the bone is not healed. And this is a false joint or a congenital pseudarthrosis. Now, 50% of these patients will have associated neurofibromatosis. And if the neurofibromatosis isn't diagnosed before we see them, it's something that everyone gets sent for evaluation for, because this is obviously very important to pick up the neurofibromatosis component. Congenital fibular deficiency is another of the congenital etiologies. This is far and away the most common of the long bone deficiencies. It's characterized obviously by a partial or complete absence of the fibula with associated anomalies. So fibular deficiency falls into a spectrum, and it really falls into a spectrum of associated anomalies from the hip down. And this can include hip dysplasia. It can include femoral shortening as well as tibial and fibular shortening. Will typically be associated with additional knock-knee on that side. So genu-valgum is commonly associated with this because they will get a hypoplasia of the lateral femoral condyle. So they will naturally drift into knock-knee. They'll have foot and ankle anomalies, and because of associated foot deformity, such as a tarsal coalition in the foot, primarily in the hind foot, will cause ankle abnormalities and a ball and socket ankle joint. And then if they're going they will frequently be missing the lateral raise of their foot. But there's a huge spectrum of fibular deficiency, from very, very subtle changes where it is only identifiable on a radiograph measuring the lengths of the fibulas, to complete absence and having one or two ray foot and significant deformity. So there's a huge spectrum of this condition. When we talk about neuromuscular disorders, the most common that we see is demonstrated by the image on the right-hand side. That is what we consider to be a high arched foot with a varus hind foot. So the foot is rolling, looks like the ankle is rolling out, the heel is in. There's this cavo-varus foot deformity, and this is very typical of an underlying neurologic condition. We always worry about when we see it in a unilaterally, we worry about something coming from the spinal cord. Is there a spinal tethering? If we see it bilaterally, then we think of more of the Charcot-Marie tooth, the hereditary motor sensory conditions, particularly if you ask and you say, the family starts to tell you that, we have a lot of people in the family that have high arches, and many will tell you that they have already been diagnosed with Charcot-Marie tooth disease. But this needs to be sort of high index of suspicion for a condition like this. And this, again, will give you leg length differences. Post-traumatic leg length differences is usually pretty easy to identify up front, because there is a traumatic event that is usually easily identified and is typically already being followed by some physician who's treating the fracture. But there are times where we definitely see kids who had an innocuous injury and didn't receive treatment, and then come, and when we obtain an x-ray, we find that they've had an injury to the growth plate along the way. And there are definitely different techniques for addressing the physeal disturbance in addition to addressing the leg length difference. There are other physeal growth disturbances, infection, common. We commonly see leg length differences in the very small child that may have had an infection after spending time in the intensive care unit as an infant. Enchondromas, osteochondromas, unicameral bone cysts, post-radiation, if they've been treated for a malignancy along the way, Blount's disease, Perthes disease, all of these things affect the growth of the physes and a growth of the lower extremity, and therefore will induce a leg length difference. Hemiatrophy syndromes, the young lady that you see in the right-hand picture has Russell-Silver syndrome, so they are of a small stature, but they will also have hemiatrophy. So one side will be shorter than the other, right, and smaller than the other. The TEV, I suppose I should have written that out. That's talipes equinovarus, or a club foot, which a club foot is really just an abnormal development, basically from the knee down. So not only will the foot be deformed, the foot will be small, but you'll have atrophy of the calf muscles, and the leg itself will also be a little bit smaller and therefore induce a limb length difference. So these type of etiologies are fairly easy to pick out because they're going to be identified before they present with a leg length difference. But knowing that these conditions can have an associated leg length difference, it's important then to talk with the family about that, warn them, or at least be able to easily explain why that's happening. Just to touch on, again, the apparent leg length difference. And this goes back again to a really good physical exam in the small child. This is the picture on the right, the x-ray of the lower extremities. If you look closely, you'll notice that there's a dislocated hip on the right side. This is a 17-month-old child who came walking into clinic, and the family was concerned because it was walking up on their right toe a little bit, and they felt to have a leg length difference. And yes, they do have a leg length difference, but it's an apparent leg length difference. It's not a true leg length difference because there's actually no difference in the length of the femurs or the tibias, but with the hip dislocated, it gives that appearance of the limb length difference. The key here is the physical exam. There's going to be asymmetry, not necessarily in the internal or external range of motion, but if you try to abduct the hip, there's going to be asymmetry in the abduction. So anyone that comes in limping under the age of 5, this is going to be again, the hip exam is a really important part of the physical exam. When we talk about the etiology of leg length difference and the one leg being longer, so sometimes you have to look at the leg length difference to say, okay, is the short leg the abnormal leg, or is the short leg the normal leg, and it's the long leg that's truly abnormal? So there are definitely cases where we see that. You can have a post-traumatic overgrowth syndrome. We know that in the young child, when they break their femur, someone who's 2, 3, 4 years of age, that break their femur, when it heals, it's very common that they have an overgrowth of the femur by up to an inch. So we see that in certain injuries, that lower extremity or that segment of the leg will respond to the fracture with a healing response that will cause the leg to actually grow a little bit longer. We know that there are soft tissue overgrowth syndromes. We see this in neurofibromatosis with Klippel-Trenaunay syndrome, Beckwith-Wiedemann, Proteus, and what we call idiopathic hemihypertrophy. These are kids that will present with legs that are longer than the normal side. Many of these will also have, these soft tissue overgrowth syndromes will have muscle or soft tissue girth that's bigger than the normal side. So that's actually that makes it a little bit easier. When you measure the circumference of the thigh, you measure the circumference of the calf, and you match that to the other side, and you realize that the one side is bigger, then you realize that that's out of proportion, and then it's going to be an overgrowth syndrome. These are important to recognize because they will all have other associated things that will need to be dealt with. The most common that we see is the idiopathic hemihypertrophy. These are kids that will present either with isolated leg, thigh and leg, or even have an entire side of the body a little bit bigger than the other side. That can affect the upper extremity and even the face. The idiopathic hemihypertrophy, the key there is that can be associated with Wilms tumor. Institutionally, we recommend abdominal ultrasounds from the age of 0 until 7 or 8 years of age, abdominal ultrasounds twice a year to help evaluate and rule out a Wilms tumor along the way. It doesn't happen very often, but we do have cases of identifying the Wilms tumor. So the key is regular ultrasounds of the abdomen. And again, inflammatory arthritis adds to that list of things that can cause the leg to grow a little bit longer. Things that you may see in your physical exam with the child as when we talk about gait strategies to compensate for limb length difference. And the family may not complain of the limb length difference and may not notice a limb length difference, but if you notice these type of things with a child or an adolescent walking or running, then it should strike a little, raise your index of suspicion just a little bit. So kids will often circumduct the long leg, so they'll swing the leg out to overcome the leg length difference of the long leg. They may walk with the long leg, in the particular the knee, walk with the knee bent. So they will walk with the short leg flat on the floor and bend the long leg. They may vault over the long leg instead of swinging it out to keep their pelvis level. They may kind of step up and over the long leg, and as we go vaulting over that, so they'll have a very distinct gait. Or they're going to walk on their toe on the short side, which is probably the most common. But to be honest with you, in the patients that we see, it's usually sort of a 50-50 split on those who like to walk on their toe and live life a little bit taller, or those who will walk flat and bend the knee of the long leg and just live life a little bit shorter. It just comes down to the sort of how the child wants to do that. And these strategies are usually not seen for differences less than 5.5% of the length of the long leg, again, which is about 4 centimeters. So this is a chart taken from a study done at this institution back in the late 90s. And what this chart shows is it shows 35 patients with varying limb length differences and increasing limb length differences as we go from left to right. The percent of the long limb is the y-axis. It's not the actual limb length difference, but it's the percentage difference. So if we put that red line at about 5% relative to the long side, you can see that those in the green are those who are walking up on their toes. And it's really once we get to that 4 centimeter or about 5. And we say 4 centimeters because the average adult has an 80 centimeter lower extremity length. And give or take a couple centimeters, one way or the other for males and females, but just use 80 because math is easy with 80. So 5% difference from side to side from an 80 centimeter adult is 4 centimeters. So that's an easy number to remember, that really anything under 4 centimeters isn't going to significantly affect gait. And it's over that 4 centimeter difference where kids are going to tend to walk up on their toes, or adolescents, adults, et cetera. So that's just an easy number to remember. We're going to jump now to the clinical assessment of a limb length difference. And this is really, if there's going to be one thing we want to take home from this talk, this is really the important one, because it's very easy to fool yourself in or out of the diagnosis of a limb length difference. So most commonly, people will lay the patient supine and try to measure the limb length differences and if you look at A on the right-hand side of the screen, that's measuring from the umbilicus to the medial malleoli on each side. And that is a way of determining the limb length difference. However, it's very easy to move the leg and move the pelvis and get fooled by that measurement. So measuring from the umbilicus and measuring from the anterior superior iliac spine are common measures. So in B, the middle image on the right side, measuring from the umbilicus gives the appearance of a leg length difference when there really isn't one, because you can see on that image the pelvis is oblique. And by just moving the pelvis obliquely, you can make, in this case, the left side seem longer than the right, where it may measure differently, but ultimately it's not any different if you level the pelvis. And that's really important on how you position the legs. And C is the same thing, using the anterior superior iliac spine to measure. You can see that even with the obliquity of the pelvis, that measures, you will then get equal measurements. So you have to be very careful. This is a method that we don't recommend. It's, again, prone to error, often not reproducible, because you can measure them one day, and if they're lying just a little bit different, it's going to look different, whether it's 1 hour later or 1 day later. So our preferred method is to have the patient standing. We want to level the pelvis, and we use graduated blocks. We're lucky enough to have blocks lying around every clinic all over the place. If you don't have blocks, you can use books. You can use whatever it takes for the patient to stand on and level that pelvis, and then measure what they're standing on to identify what that leg length difference is. So very simple clinical exam with them standing. And will stand with the patient facing away from you. So you're standing behind them. You're putting your fingers on their on the top of their iliac crest, which can be difficult to do in some larger, fluffier patients. It is admittedly a little bit hard to do, but again, it's going to be the most accurate way of identifying that discrepancy. So this is just an example of me standing behind this patient. I can see their lower extremities. We're making sure that they're standing with their foot flat on the block and their knees fully extended. And I've got my hands on top of the iliac crest. And this is just another view. And again, you can see, and you'll have to believe me on this one, that my fingers are at the same level on the iliac crest. So the iliac crest is nice and balanced with this 2.5 centimeter block underneath this patient's foot. Now, there are difficulties if there are associated conditions with these patients. Joint contractures are difficult because they can give the appearance of a leg length difference that may or may not be there. So these images are a picture of a child who has hemiparesis on the right side. So this patient standing looks like they have a significant leg length difference on the right side. You know, they're standing on their toe, the heel is off the ground, the left foot is flat on the ground, and you can see the knee is obviously higher on the right side than on the left. But this is not a true leg length difference. With this type of patient, you have to be very diligent about looking for contractures of the joints. So hip flexion contractures, hip contractures, whether they be hip flexion contractures, or in this case, an adduction, an adduction contracture. If the hip is adducted, then for them to get their foot underneath them, they're going to swing their foot underneath them, and they're going to end up with a very oblique pelvis. That leg is going to toe is going to come up off the ground so that they can get it underneath them, and it's going to give them that appearance of a leg length difference. Hip flexion contractures, knee flexion contractures can all give the appearance of a discrepancy when there really isn't one. Equinus contractures, so contractures at the ankle, also can give that appearance. So because of that, then it becomes a little bit more difficult to measure, particularly if you're using a supine measurement. But again, physical exam is really key to addressing these issues that can affect the diagnosis. Again, similarly, pelvic obliquity. When we talk about pelvic obliquity, we're talking about conditions that can affect the lumbar spine. And then again, deformity of the pelvis itself for any number of reasons. And these are the type of things that will then be easily identified on radiographs as well. Scoliosis. Scoliosis is one that it is not uncommon that we will have a patient referred in for a leg length difference when really they have scoliosis, and vice versa, where they'll fail a screening thinking that they have scoliosis when really they don't, and it's a leg length difference. And this is where the physical exam part really is important, again, and having the patient stand and equalize the leg length. Because a lumbar scoliosis, like you see in this image on the right, you can see that this will give you pelvic obliquity. So if you're standing and having that patient stand and you have their fingers on their iliac crest, then they're going to have one that's going to be higher than the other. And that may make you think, okay, they have a leg length difference. Now, if you then level the pelvis, you put a little block or a book underneath their foot and level that pelvis, if the scoliosis is related to a leg length difference, that scoliosis is going to go away when you level the pelvis. But if you level that pelvis and you do your forward bend test again and they still have the scoliosis, then it's the scoliosis that's driving the pelvic obliquity and making it look like they have a leg length difference. So it's important to try to decipher between those, or as it says, you can have them sit down. And if it's the leg length difference driving the scoliosis, when you sit and you look at their back, the scoliosis will go away. So very important to identify each of those conditions. So now that we've diagnosed the leg length difference, what do we do radiographically to help, one, to look at any associated anomalies, or just to be able to measure that leg length difference as well, and what x-rays should you get? Well, first of all, I would say, one, you don't have to get x-rays. If you're concerned enough about the leg length difference, we're happy to take care of that and happy to get radiographs on our own. But if you're going to send someone for a radiograph, particularly if you really don't think they have a leg length difference and you want to appease mom or dad or grandma that there isn't a problem with their leg length difference, then the ideal image is to get a standing AP of the both lower extremities. And if you think that there's a subtle difference, you want to have them stand on that same block or book that leveled their pelvis in the clinic room so that when they're taking the x-ray, they're standing with their pelvis nice and level. The important thing, again, correct the discrepancy, because when you have this standing film, you not only can see the leg length difference, but the standing film will also give you an idea if there's any associated angular deformity at the knee or ankle. And that's important for us when we start talking about the potential need for treating these. Just to touch on the different radiographic techniques, the AP of the lower extremity standing is the important one. There are other ways that different radiology techs will do this. Teloretinography is the simplest, but it's also the most subject to magnification error, where the patient is lying down and they take one image centered at the knee. So you get parallax at the hip and the ankle, and you don't have a very good appreciation for the joint deformity, and you can't measure the actual lengths of the leg off that image. Orthoretinography is another technique where they use 3 images and then stitch them together. Again, that's 3 exposures. That's a lot of radiation, less magnification error. And when done with a ruler, you can measure the leg, but it's a lot of radiation. And you'll notice that these first 2 techniques and this third technique of doing a scanogram, these are the patients are supine. So you can't get an idea of what their lower extremity alignment is like when they're standing. Scanograms, very commonly used, particularly in kids who have joint deformity that can't stand with their legs straight. Then this is a technique where you take a picture at the hip, the knees, and the ankles with a ruler in place, and you can measure the distances between them, and you can get an idea of what the femur length and the tibial lengths are. However, you can't see, again, associated deformity associated with those bones. So that's a definite drawback. Though we still use this technique, we don't use it nearly as much as we used to. CT, scanograms, ultrasound, there are roles in very select cases, but again, for the evaluation or assessment of a limb length difference, these are not going to be used routinely. These are for very select cases. The use of EOS, and the image on the right actually is the EOS machine. This has been I wouldn't say revolutionary, but has definitely changed our practice for the better for multiple reasons. This is a radiographic technique that uses microdose radiation exposure compared to a standard radiograph, so it's much safer for the child, but we get a lot more information with a lot less radiation. We get simultaneous frontal and lateral imaging without magnification. So the patient can either sit or stand, and over the course of a few seconds, the image is obtained. Basically, well, we use this for scoliosis and for lower extremity, but in this case for lower extremity, they start at the top of the pelvis, and that the machine scans the lower extremities and gives you a non-magnified view of the lower extremities. So we can get actual length measurements from this and not have to worry about having a ruler in place. The only drawback to the EOS is the patient has to be old enough and has to be able to stand still for those few seconds while that image is being done, because if there's any motion, then it affects the look of the lower extremity, and it can give you the idea that there is a deformity of the lower extremities that really isn't there. The upside too is that in select cases, there can be post-production 3D imaging that can be created from the 2 views that we get. And we don't get 2 views on everyone. When we're doing the AP of the lower extremities, really we're just getting the standing, just the frontal view most of the time. So there's a lot that we can do with this, and the EOS has really made it safer for our kids and has given us more information to be more accurate at what we're doing. So this has been a big step forward for us, both on our main campus and on our Frisco campus. We're very lucky to be able to have one on each campus. So how do we predict what the limb length discrepancy is going to be now that we've identified it, now we've taken a picture of it? Next question is, so what? Well, that's the next question. So predicting what the discrepancy at skeletal maturity is going to be is really the most important thing that we do, because that's what families want to know is, okay, Tommy or Susie is, 5 and has a 1 centimeter leg length difference. Is that 1 centimeter leg length difference going to stay 1 centimeter until they're done growing? Or is that going to get worse? And if it is going to get worse, what is it going to be? Because depending on what it's going to be at skeletal maturity will depend on, that will have a significant effect on what we recommend during that time period, from the time that they're 5 to the time that they're done growing. So there are different ways of doing this, and I'm not going to get into the weeds too much on these different ways of predicting it, because some of these are historical, but it just gives you a perspective of how we do this. This lists all of the ways we do it, and we're going to touch on each one of them for just a second. The White-Menelaus formula. This is actually pretty important because it helps in the describing parents' sort of growth of the lower extremity. So basically, what the White-Menelaus formula tells us is how much growth per year we get at each growth plate. So you can see that the distal femur and the proximal tibia together, this 9 millimeters and 6 millimeters, that accounts for 1.5 centimeters of growth per year on average. Now, no child grows 1.5 centimeters from their distal femur and proximal tibia every year until they're done growing, right? There's some variation in how much they grow. But if you look at it over time, on average, that's what it is. And that accounts for 65% of the growth of the lower limb. So we know that the proximal femur grows about 2 millimeters a year, the distal femur about 9 millimeters, proximal tibia about 6, and the distal tibia about 4. So knowing those are excellent numbers to use when we're trying to calculate the impact of a physeal arrest. If there's been a trauma and that growth plate is injured, then we know, and stopped growing, then we know about how much discrepancy over the next few years is going to happen. And when we talk about doing an epiphysiodesis, this formula is what's now been proven by some work at our own institution, is probably the best way to calculate when to do an epiphysiodesis, meaning when to slow down the long side so that the short side can grow and catch up. And this is all based on, again, the growth, what we think is what we know to be the growth at each of those physes, and knowing that girls grow to 14 and boys grow to 16, we can then do those calculations fairly easily. The Green-Anderson growth remaining charts are charts that you may have seen along the way. We don't really use them as much as we used to because we now have these other techniques that have proven to be better. The downside of this growth remaining is that a lot of data and a lot of people use these, but these were only created out of 67 boys and 67 girls from the 1950s, and I think then they were all white. So we're talking about a very select population of kids that does not necessarily represent today's children, or certainly across a spectrum of different races and cultures. The Moseley straight line graph is actually the most accurate method of predicting what limb length discrepancy is going to be. But it also is one of the most difficult to use because you have to have multiple time points. So you need at least 3 scanograms, or in our case, EOS measurements. So you need 3 measurements of the lengths of the lower extremities separated by at least 6 months with associated bone age, meaning getting a hand or an elbow to help identify what the bone age is, so you can then predict what the discrepancy is going to be. And you can use this graph to help predict or identify when is the best time to intervene with an epiphysiodesis. So we still use this we don't use this as much clinically as we use for research purposes because we have other techniques. And finally, the multiplier method, when used for predicting limb length differences, is actually the simplest and is prove to be just as good as any other technique. And this is the advent of technology, right? So what you're looking at on the right is a screenshot of an app that has been developed based on the work of Dror Paley, creating different multipliers to be able to predict not only limb lengths and therefore limb length differences at different ages and at skeletal maturity. So you can plug into a little app what bone segment you're looking at, whether it's the femur, the tibia, or in this case, the entire leg, male or female. You type in their age, what discrepancy you have at that age, and it's going to tell you then what the discrepancy is going to be when they're done growing. And this is fairly accurate for the prediction of limb length difference. It's not particularly good for predicting when to do an epiphysiodesis, but it's very good at predicting what the overall length difference is going to be. And if families ask you, so just to be clear, what this says is that the easiest lower limb multiplier to remember is 2 times at the age of 4 for boys and 3 for girls. So that's for limb length. That's not for overall height, just to be clear. The overall height is 2 times, and for girls, it's just under the age of 2, and for boys, it's just over the age of 2. You multiply their height by 2, and that's roughly their pretty good guesstimate of what their overall height is going to be. This is another important point when you're talking to a family or about a congenital deficiency or congenital limb length difference, because this adage, which makes you think that it's some sort of urban myth or this is some sort of statement that doesn't necessarily stand the test of time. Well, this really has stood the test of time. The percent of lower extremity or limb length difference remains constant throughout growth. So a child who has a congenital femoral deficiency, who has a fibular deficiency or a tibial deficiency, that limb length difference, what you see when they're born, from a percentage standpoint, will remain constant until they are done growing, which again goes to the math that we started to do earlier, where if you look at the average lower extremity length of 80 centimeters, if I meet a family for the first time when the child is, let's say, 6 months old, and we can measure the length of their legs, and we know that there's a 10% difference between their right leg and their left leg at 6 months of age, then I can predict that when they're done growing, they're still going to have that same 10% difference between their legs. Now, the absolute value of that obviously is going to be much greater at skeletal maturity because their overall length of their leg is greater. So in this case, if for an average patient, and obviously not every patient is average, but you can gauge that based on the parents and the siblings. But if the average adult is 80 centimeters and at 6 months of age, they have a 10 centimeter difference or 10% difference, then at skeletal maturity, they're going to have an 8 centimeter leg length difference. And in our own institution, this is held true in 85% of the patients that we looked at that had fibular deficiency, and this was well over 100 patients. So that holds true pretty true. And it's a pretty good starting point for a discussion for the family, because what they see as not a very big discrepancy when they're really little can prove to be 20 centimeters when they're done growing. And that's a much different discussion when you can show them what 20 centimeters looks like and how that's going to have an impact on a treatment plan. And then when we talk about treatment and general principles, just so you have an idea of what we're thinking, and it's not always safe to know what we're thinking, but in this case, it's good to know what we're thinking. When we talk about the management of limb length differences, again, less than 2 centimeters, we do not generally treat less than 2 centimeters because we know in the long term that's not going to be a problem. 2 to 5 centimeters, we're talking about a contralateral epiphysiodesis, again, slowing the growth of the long leg down and letting the short leg catch up. And generally for more than 5 centimeters, then we're looking at having to do a lengthening, because to do an epiphysiodesis, to slow the long leg down more than 3 or 4 centimeters, then starts to affect overall height. And that's a lot to ask an epiphysiodesis to do as well. It isn't always quite as accurate. Limb lengthening, again, for the patients where we have a greater discrepancy of over 5 centimeters. We break that, then start to break that down. If we're going to do 5 to 7 centimeters, that's usually one lengthening. We usually will only lengthen the bone about 15% of the long leg, and that's roughly, and it's generally about 5 centimeters, the femur being easier to lengthen than the tibia. So if we can get 4 or 5 centimeters, that's a good lengthening. If we have someone who has a 7 to 10 centimeter discrepancy, then we're looking at having to do a lengthening plus an epiphysiodesis or 2 lengthenings. Sometimes the family does not want to do an epiphysiodesis. They feel very strongly about not touching the good leg, and that's understandable. Again, 10 to 15 centimeters, you're looking at 2 lengthenings in epiphysiodesis. 15 to 20 centimeters or more, you're looking at 3 centimeters, 3 lengthenings. And anytime we do a lengthening, you have to, we tell the family up front, you need to commit 6 to 12 months to doing this. So it's a lot to ask under the best of circumstances. And when you get 20 centimeters, 15 to 20 centimeters, you then start to have to talk with the family about is attempt at lengthening and reconstructing that lower extremity going to be worth the time, the effort, the pain, and everything that's involved. And we talk about potentially then doing an amputation and prosthetic wear. Again, treatment modalities, we're just going to go through this just quickly. Again, a small discrepancy, no treatment. If the discrepancy is greater than 2 centimeters and they have a hemiparesis or some sort of paralysis, a stiff leg gait because of stiffness at the knee, or they're particularly weak at the hip, then we won't recommend treatment if it's over 2 centimeters and they have these type of things, because if they have equal leg lengths and paralysis or a stiff leg or abductor weakness that can't be corrected, abductor weakness that can't be corrected with therapy, then equal leg lengths will make it difficult for them to walk. They will have trouble clearing their foot. And therefore, having a shortening associated with certain conditions is actually functionally better for them. Kids who have 2 centimeters or 2.5 centimeters, and we recommend not doing anything, but the family is very, insistent on trying something. And if sometimes they need to do something to show that it really doesn't make a difference, then using an in-shoe lift is really the best place to start. A lift inside the shoe, usually you can only put about a centimeter lift inside a shoe before the shoe becomes too tight and it becomes difficult to wear. So you can make up half of a 2 centimeter difference inside the shoe, and most of the time the kid will come back and say, I can't tell any difference and I don't care. And that's good, because then that just reaffirms with the family that they don't care and it's not going to make a difference. An extension orthosis, this is for limb length discrepancies that aren't easily managed by a shoe lift, usually if you have greater than 5 centimeters of a lift. So this is simply a prosthetic that's created for the foot that is there and makes up the difference. So you basically have a foot on a foot. And the tennis shoe here is the prosthetic foot, and above that is the foot of this patient in equinus, kind of sticking down into the prosthesis. Oftentimes, an AFO or a KAFO is attached. There are many kids who use extension prostheses and then either go on to an amputation or use extension prostheses and go on to lengthening. And then there's lots of kids who use an extension prosthesis and they just love it and they don't really care about anything else, and that's all they use. And as this last bullet point says, there's probably a whole bunch of kids that end up having treatment that probably would have done better just with an extension orthosis. But there's a cosmetic issue to it, and some people don't like the idea of that. But that being said, it really works well. And then when they have a good knee and a good hip, they're very, very functional and don't have any problems with that. Epiphysiodesis, you've heard me use this term several times, and again, slowing the growth of the long leg and letting the short leg catch up. Classic indications are 2 to 8 centimeters of discrepancy. I need to change that back to 2 to 5 centimeters. Really, again, 8 would be too much. There has to be adequate growth remaining. So we usually say there has to be at least 2 years of growth remaining to make the epiphysiodesis worthwhile. And that's where bone ages of the hand and elbow come in to help us identify whether there's 2 years of growth remaining. And some people will say they should be of average height. Some people feel more strongly about taking their predicted height into account. Most of the epiphyses DCs we're doing usually will decrease the patient's height an inch or less. So their overall height an inch or less, maybe an inch and a half, and rarely not 2 inches. So if you're talking about someone who's 5'6" going down to 5'5", that's usually probably not a big deal. But there are some kids who potentially are going from 5 foot to 4'11", which can be a functional difference. And this is something just to take into account and talk with the family about. Of course, when we're talking about epiphysiodesis, or we're thinking about doing an epiphysiodesis, which bone, whether we're doing it in the femur or tibia, again, are there any conditions where equalizing the leg lengths would be a bad idea? And that's what we need to talk about with the family, in addition to the idea of operating on the good leg. Again, there are many families that feel strongly that they don't want to touch the good leg. Complications happen. Inaccurate correction, meaning overcorrection or undercorrection, can happen. We think we've certainly gotten better at this over many, many years. Again, using the white Menelaus technique helps us, and the other techniques we have to help predict this. Asymmetric closure happens in less than 5% of the patients, meaning that you go to slow the growth down and one side, for whatever reason, despite your best effort, doesn't stop growing and can make the leg grow crooked. But that's something that we follow very closely and jump on, and try to get before that creates a problem. It's the procedure of choice when applicable, and it is by far and away the most common procedure we do for limb length differences. Surgical shortening is another technique. This is one that used to be popular, and that in the 15 years that I've been practicing at this, 16 years now at this institution, we have not done ephemeral shortening. It used to be very popular with our lengthening techniques. This has gone away as much. Particularly, we've also learned that if you lengthen or if you shorten too much, it affects the function of the muscles and can make it difficult to get the motor the strength back and some of the coordination back when you shorten the muscles, shorten the bone, and the muscles aren't functioning at their normal length. So it's a technique we use, but one that is not commonly used anymore. And this is just an example of a shortening. The image on the left shows is a lateral of the femur, and the bone that you see both in front and in back of the femur here is the segment that was shortened using an intramedullary saw to cut this out and have these done. So you don't need to do this by a big open technique. You can do it through small incisions and then insertion of an intramedullary rod. Limb lengthening, and we could spend, and maybe at some point I will spend an hour talking about limb lengthening, because this is a very big subject in and of itself. But the indications for limb lengthening, the motivated patient, we say 8 to 18, and again, there's a lot of discussion and philosophical issues about doing that, and I'll explain in just a minute. And greater than 4 centimeters of shortening, at least 4 centimeters of shortening is helpful for us to do a lengthening, because it is a big deal. And if it's less than 4 centimeters, then an epiphysiodesis most commonly will work for us. There are many complications, potential complications associated with lengthening, so this isn't something that we take lightly. How do we do it? Well, we do it with either external fixation or we do it with an intramedullary rod, depending on whether there's any associated deformity in the bone. Calostasis is a technique where, basically, to make a long story short, we're fooling the body into thinking it's broken. You cut the bone, you let it start to heal just a little bit, and you slowly and gradually pull the bone apart. And we've identified that if you do it at about 1 millimeter a day, or just under 1 millimeter a day, you can slowly pull that bone apart. The body thinks it's broken, it'll start to heal. You keep pulling it apart, and it'll keep healing in behind it, so that over time, this heals. The use of an external fixation has some advantages in that there's nothing inside the bone or inside the body. No bone grafting is needed for lengthening, and it's very predictable from a healing standpoint, whether you use external fixation or an intramedullary rod. This is an example of intramedullary lengthening. This was a rod that was placed through the knee, so in a what we call retrograde fashion. This was a teenager who had Perthes disease, and you can see the hip deformity, and had a 4 centimeter limb length difference. And you can see that over 4 weeks, we had almost regained his full length that we were looking for. But then over at 3 months and 6 months, you can see the healing of the bone. Considerations for limb lengthening. When we're talking about, again, talking to a patient about limb lengthening, the important thing is to know what is the predicted, what is the predicted limb length difference at maturity, because that's going to again affect how many lengthenings they might need and other associated procedures. The etiology. If we have to lengthen someone who has a congenital deficiency, that's much harder than lengthening someone who had a growth disturbance after trauma or after, let's say, cancer or tumor. When you're a congenital deficiency that is being lengthened 10 centimeters, that's a limb that never wanted to be 10 centimeters longer than it currently is. So when we are trying to lengthen a congenital lower extremity, congenital deficiency, the soft tissues often want to fight back. It's very easy to lengthen bone, and I tell this to every family. We can lengthen a bone almost infinitely, but you're lengthening muscles, tendons, nerves, and all of these things will oftentimes fight back, particularly if it never wanted to be longer than what it's pre-programmed to be in a congenital deficiency. So all of these things are important to talk to the family, because even though we have a goal of lengthening 5 centimeters, we may never get to 5 centimeters. We may lengthen 2 centimeters and they start to develop difficulties with the hip and knee that force us to stop. Amputation is always an issue, and amputation is part of lower extremity reconstruction. If the discrepancy is 20%, or more, we're talking again 15 or north of 20 centimeters and associated deformities, then an amputation is going to be in the best interest of that child from a functional standpoint. All of our decisions are made, whether it's for lengthening, shortening, amputation, doesn't matter. All of the decisions we're making is what is going to be in the best interest from a functional standpoint for this child. How can we make them more functional with the least amount of surgery and allow them to keep their childhood as long as they can? And sometimes the best answer for that is an amputation, so that they're up and running and doing everything with their peers instead of having multiple surgeries along the way. And these are important discussions that we have with the families every time we see them. So again, timing of lengthening, just as we wrap this up, Epiphysiodesis, again, we try to do this near maturity so that we time their correction of the short leg catching up to the long leg. We time that so that they're about done growing when it happens. A single lengthening, we usually try to wait till after skeletal maturity because the one, you know exactly how much you need to get, and second of all is the emotional and psychological maturity of the patient is really critical, which we're going to talk about here. Double lengthenings, one will generally be before and one after skeletal maturity, depending on whether an epiphysiodesis is done. And then 3 lengthenings, there's this rule of 4s where oftentimes you do the first one, you're looking at 4, 8, 12, and 16, for times of treatment. And there's nothing about being, you don't hold them to that, but it gives the family a good idea. If you can give them a plan of care when the child is 6 months of age, an idea of what they're looking at and when they're looking at it, it goes a long way for putting them at ease that there's a plan. And even though it's going to take some time, the upside is that none of this has to be rushed into. How do we avoid complications? Well, avoiding limb lengthening avoids complications, and that's why we make a big deal about what we do. We make a big deal about it because complications can happen, and we make a big deal about this because this is a big stressor for the patient and the family. Again, limb lengthening is a 6 to 12 month commitment for any patient or family, and therefore we need to make sure that everyone is on the same page. We know from studies here at this institution that during lower extremity reconstruction, whether it's lengthening or deformity correction, that there is a significant effect on the patient, whether it be mental status, loss of sleep, loss of appetite, academic problems. We preoperatively screen all patients and families being considered for any sort of limb lengthening. The more we learn about the patient, and this is exactly what I tell them, the more we learn about the patient, the more they learn about us, about what we're doing, how we're doing it, and more importantly, how to cope with it, then the better they're going to do. And we've proven that scientifically, that getting them ready beforehand makes a big difference while we're doing it, and it makes a big difference afterwards. And treating pain, sleep disorders, loss of appetite, we treat that very aggressively during treatment. There are red flags that we've identified. Single-parent families, multiple surgeries, pre-existing psychiatric conditions, and young patients are also red flags for potential complications during lengthening. It's not a contraindication to lengthening, but these are the things that need to be addressed because it affects the family and the patient, and these things affect outcomes. These red flags are associated with all of these things: unplanned operations, unplanned readmissions, more narcotic use, longer inpatient stays, outpatient visits, longer time either in their external fixator or before their weight bearing with intramedullary rods, increased need for antibiotics, poor outcomes. So again, it's incredibly important that we identify these patients ahead of time and work with them ahead of time. So in general, the older the better, which is why we like to wait till they're closer to maturity. Over 12 is ideal, just from they're more physiologically and more psychologically mature. They can understand the process a little bit better, and they need to participate in their recovery. Again, I say this to them all the time. This is something we have to do with them and not to them. You can do it to them when they're below 5, and that's just something that we have to deal with on certain occasions. But when it comes to lengthening when they're older, they have to be on the same page. They have to participate, because if they don't participate in the rehab, then everything is going to go terribly wrong. Lengthening, you probably shouldn't even start it. Again, less than 5, you're doing it to them. 6 to 8 years of age, you're doing it with them. And at 6 to 8, psychologically, they're more likely to follow authority and follow the exercise program and work with their physician and their therapists. It's the 9 to 12-year-old that is the most developmentally difficult time, because they start to be resistant and stubborn and can't follow directions. And if you have your own children at that age, you realize that, yes, I couldn't fathom doing a major surgery to them where for 6 months they're going to be, dealing with a stressful condition. Pre-existing mental health conditions are really important to identify. So again, to wrap this up, with careful planning, patient selection, monitoring of lengthening, meticulous care of the soft tissues, and judicious goals, good outcomes with preservation of function are achievable when we're talking about limb lengthening and reconstruction. Summary of limb lengthening management. Sort of what we talked about today is the importance of a good history. The good history and a careful physical exam gives you a really good idea of what the etiology of a limb length difference is and helps you to identify what the limb length difference is, where it's coming from. The radiographically, again, standing AP of the lower extremities is the ideal with a block. From the physical exam standpoint, assessing them standing with something under their foot to level the pelvis is really important. Predicting their leg length and maturity has a trickle-down effect as to what we're going to do and when we're going to do it and what their treatment options are. And then we have to be very careful in how we plan those and how we execute those. And more importantly, how we prepare the family for all of those, which is a huge part of what we do and why we focus so much on the psychology side of things. Thank you very much for your time today. Do not hesitate to reach out to me if you have questions about anything we talked about today or any concerns about a patient with a limb length difference. Thank you very much.